We've spent the last several lectures building up every opioid you'll actually use. Today, we're covering the drug that undoes every single one of them. Naloxone is the reason opioid overdose doesn't have to be a death sentence. It's carried by paramedics, handed out at pharmacies, and sitting in most anesthesia carts. And understanding exactly how it works, and exactly where it falls short, is genuinely life-saving knowledge. Let's get into it. What kind of drug this is? Naloxone is a pure opioid antagonist, meaning it has essentially zero agonist activity of its own. It doesn't dull pain. It doesn't sedate. It doesn't do anything except block the receptor and get out of the way. It's non-selective, sitting on all three opioid receptor types, mu, kappa, and delta, though its affinity for mu receptors is the strongest of the three, which is exactly why it's so effective against the drugs we've covered throughout this series. How it actually works. Picture an opioid molecule sitting in a receptor, like a key in a lock, turning it, triggering the whole cascade of effects we've discussed. Naloxone is a different key that fits the same lock, but doesn't turn it. It simply occupies the space, physically displacing the opioid agonist off the receptor without activating any of the downstream signaling itself. This is competitive antagonism. Naloxone and the opioid are competing for the same binding site, and whichever one has more molecules present or binds more tightly wins that competition. Once naloxone displaces an opioid from mu, kappa, and delta receptors, it reverses respiratory depression, sedation, analgesia, pupil constriction, bradycardia, and hypotension. Notice what's on that list. Analgesia is right there alongside the effects you actually want reversed. That's not a side detail. That's the central tension of using this drug, and we'll come back to it. How it's selective despite being non-selective. Here's a subtle but important point. At the receptor level, naloxone doesn't discriminate. It blocks all three receptor types indiscriminately. But clinically, we describe it as selective because of how narrowly we actually deploy it. It's used specifically to treat opioid-induced respiratory depression, whether that's showing up in the postoperative period or in a neonate whose mother received opioids during labor. It's used to facilitate treatment of deliberate opioid overdose, and it's used diagnostically to detect suspected physical dependence, giving a small dose and watching for withdrawal symptoms to confirm dependence is present. The receptor mechanism is broad. The clinical application is narrow and deliberate. Getting it into the patient. IV administration gives you complete 100% bioavailability. IM, or subcutaneous routes, only get you around 35 to 40%. Intranasal delivery, the formulation most people recognize as Narcan in its community-facing form, runs around 50% bioavailability. Oral administration is poor, and this deserves its own explanation. Naloxone does get absorbed from the gut just fine. The problem is first-pass hepatic metabolism. The liver strips away so much of an oral dose before it ever reaches systemic circulation that oral naloxone ends up only about 1/5 as potent as the same dose given parenterally. This is exactly why naloxone always shows up as an injectable or intranasal product, never as a tablet you'd take by mouth. Distribution and metabolism. Naloxone crosses into the CNS rapidly, which is part of why it works so fast. It also crosses the placenta, and hold on to that fact because it becomes genuinely important in a specific clinical scenario we'll cover shortly. The liver metabolizes it through glucuronidation, producing naloxone 3-glucuronide, an inactive metabolite. Elimination half-time runs 60 to 90 minutes. The single most important pearl in this entire lecture. Here it is, and if you remember nothing else from today, remember this. Naloxone's duration of action, 30 to 45 minutes, is shorter than the duration of most of the opioids it's given to reverse. Look back at everything we've covered. Morphine lasts 3 to 4 hours. Fentanyl lasts 30 to 60 minutes. Methadone lasts more than 24 hours. Naloxone's own effect runs out in 30 to 45 minutes because it gets removed from the brain so rapidly. Picture the timeline. A patient overdoses on morphine. You give naloxone. Within 1 to 2 minutes, they're breathing again, awake, alert, seemingly fine. 45 minutes later, the naloxone has worn off. The morphine, which was always going to last 3 to 4 hours, is still sitting there, at a concentration that hasn't meaningfully changed. The respiratory depression you thought you'd solved simply returns. This is renarcotization, and it's the single reason anyone who receives naloxone needs sustained monitoring, not a one-time dose and a discharge. The mismatch between naloxone's short duration and most opioids' much longer duration is genuinely the most clinically dangerous gap in all of opioid pharmacology. Dosing. Initial 1-fee dosing for reversing respiratory depression, 1 to 4 micrograms per kilogram, typically translating to 40 to 100 micrograms in an adult. IM or subcutaneous, 0.4 to 2 milligrams. Intranasal, 2 to 4 milligrams, the community overdose reversal dose most people are familiar with. For sustained reversal, particularly with neuraxial opioids, where you want to maintain analgesia while preventing respiratory depression, a continuous infusion of 5 micrograms per kilogram per hour threads that needle. Given that low, steady infusion rate prevents ventilatory depression without stripping away the analgesic benefit the neuraxial opioid was providing in the first place. The titration principle that matters most. Here's a genuinely important clinical concept. The goal of naloxone isn't necessarily complete arousal. The goal is restoring adequate ventilation. Full reversal of opioid-induced respiratory depression inevitably comes with full reversal of analgesia. Your patient goes from comfortable to suddenly in severe pain. But it's often possible to titrate naloxone carefully in small incremental doses so that ventilation is partially, but adequately, restored, while still preserving some meaningful analgesia. This is a real balancing act, and it's exactly why naloxone should be given slowly and titrated, not blasted in as one large dose whenever possible. Adverse effects. Acute opioid withdrawal. In a patient with physical dependence, naloxone can trigger sudden, severe withdrawal, anxiety, tremors, agitation, hypertension, diarrhea. Nausea and vomiting. Genuinely common, and closely tied to both the dose and the speed of injection. Give naloxone slowly, over 2 to 3 minutes, rather than as a bolus, and you meaningfully reduce the incidence of nausea and vomiting. There's actually a protective silver lining here. Awakening tends to occur either just before or at the same time as any vomiting, which means the patient's protective airway reflexes have typically returned by the time vomiting happens, minimizing aspiration risk. Sympathetic activation. Naloxone reversal triggers a surge in sympathetic nervous system activity, presumably reflecting the abrupt return of pain sensation, combined with the sudden reversal of analgesia itself. This can show up as tachycardia, hypertension, pulmonary edema, and cardiac dysrhythmias. In rare, severe cases, this sympathetic surge has been associated with ventricular fibrillation, a genuinely serious potential complication tied directly to how abruptly analgesia and sedation get reversed. This is one more reason to titrate carefully, rather than push a large dose all at once. Crossing the placenta. Naloxone crosses the placenta readily. If you give naloxone to an opioid-dependent pregnant patient, you can trigger acute withdrawal in the neonate, a genuinely important consideration in obstetric anesthesia, and a clear reason for caution in this population. Naloxone's role in shock. This is a less commonly known but genuinely interesting property of naloxone. In animal studies, naloxone produces dose-related improvement in myocardial contractility and survival in hypovolemic shock, and to a lesser degree, septic shock. While older exploratory trials historically investigated high-dose intravenous naloxone as an experimental adjunct to raise blood pressure in refractory septic shock by blocking excess endogenous endorphins, it is not guideline-recommended therapy for shock management today. How it compares against the opioids it's reversing. Naloxone. Onset 1 to 2 minutes IV. Duration 30 to 45 minutes. Half-life 60 to 90 minutes. Purpose, reversal. Fentanyl. Onset 1 to 2 minutes. Duration 30 to 60 minutes. Half-life measured in hours. Morphine. Onset 5 to 10 minutes. Duration 3 to 4 hours. Half-life 2 to 3 hours. Methadone. Onset 10 to 20 minutes. Duration over 24 hours. Half-life 26 to 35 hours. Line these up side by side, and the danger becomes visually obvious. Naloxone's duration is the shortest number on this entire table, while the opioids it's meant to reverse run anywhere from comparable to dramatically longer. This comparison table is really just the renarcotization problem, laid out numerically. The high-yield summary. Naloxone is a pure antagonist at mu, kappa, and delta receptors, with the strongest affinity for mu. Onset is fast, 1 to 2 minutes IV. Duration is short, 30 to 45 minutes. That duration is shorter than most opioid agonists, which means recurrent respiratory depression is genuinely common and must be anticipated. For sustained reversal, particularly with neuraxial opioids, a continuous infusion of 5 micrograms per kilogram per hour is the standard approach. Sudden, full-dose reversal can trigger acute withdrawal, and the goal of therapy should be restoring adequate ventilation, not necessarily complete arousal. Naloxone crosses the placenta, which demands real caution in opioid-dependent pregnant patients. Pulling it all together, Naloxone, a drug with almost no effects of its own. Its entire job is displacement, competition, getting between an opioid molecule and the receptor it's trying to activate. Fast onset, short duration, and that mismatch between naloxone's brief window and most opioids' much longer half-lives is the single most important safety principle in this entire lecture. Never treat a single dose of naloxone as the end of the story. Watch the patient, watch the clock, and know that the danger you just reversed can quietly return before you've even finished charting. I'm Anesthesia Buddy. Stay sharp. See you in the next one.